Hey everyone, I'm John Lynn, the founder and chief editor of Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Malinka. He's CEO and co-founder at Akasa. Welcome.
Thank you. Delighted to be here.
Yeah, excited for our discussion. For those that don't know about you, tell us about yourself and Akasa.
Sure. So we at Akasa, our goal is to work with health systems to capture the patient story as comprehensively as possible and communicate it to peers as comprehensively as possible. So we do that by using the most advanced large language model AI technologies, and we applied it to multiple parts of the revenue cycle.
Interesting. Why is the US revenue cycle so complex? Shouldn't it be, shouldn't it?
It really shouldn't be. And I wrote a blog post about this, everyone's actually interested, but the reality is we have created an incredibly complex system here in the US in terms of how to pay for care. And that complexity expresses itself in a lot of very negative ways that affect the patient experience, that affect the health system provider experience, that affects really every stakeholder. And our vantage point is with sufficiently advanced AI and technology, you can account and compensate for that complexity and still deliver a great experience to all stakeholders.
Interesting. I think it's interesting in the revenue cycle space, right? We've had a lot of different technologies, computer-assisted coding, whatever, right? There's been a ton of different technologies. What limitations did those technologies kind of run into, and what fundamentally changed with large language models that is really taking it to that next level?
So the fundamental point of revenue cycle is to capture and communicate the patient story, right? That is the fundamental point. And to do that well, you have to actually be able to parse and understand the patient clinical record. Now, pre-LLM, pre-large language model, this was extremely hard to do, right? The patient clinical record is incredibly complex. We actually measured the complexity of it. There's dozens, on average about 60 documents per inpatient patient record. It's about 50,000 words long, right? So for the average, revenue cycle worker, they have to read 50,000 words. That's the equivalent of the Great Gatsby. They have to read that in 30 minutes or less, multiple times a day, every day. Of course, they're going to get things wrong, right? And of course, this is an area that AI can help with. But again, pre-large language model, this was an impossible problem for even the best AI back then to do because it was really hard to understand the clinical record, all this unstructured data. Now, with LLMs, it is actually possible. And just so folks are aware, LLMs, also called generative AI, is this new form of AI that really came onto the scene in 2023. Most people experience it in things like ChatGPT and other things, and it's remarkably powerful at understanding complex language, and we can use that to get a superpower now in the software world where you have AI that can actually understand a patient medical record that unlocks all these capabilities in revenue cycle that were impossible before.
Interesting. Many of the AI companies rely on kind of general foundation models. You talked about some of ChatGPTs, the ones that people have heard about, right? You've kind of emphasized the need to customize models for each health system. Why does that matter in rev cycle?
So the sort of general purpose models from OpenAI or Anthropic or whatever are not bad, right? They can solve a bunch of stuff, but they can solve typically the simpler problems. But it turns out when you're solving really complex problems like the ones we do in revenue cycle and inpatient coding, inpatient CDI, stuff like that, that doesn't work well enough. And so what we have done, and we've found to work effectively, is to actually tune a custom LLM per health system that understands their nuance as well. Because the reality is every health system has so much nuance that is specific to them that is different from other health systems, right? So for example, we work with Cleveland Clinic, we work with Deep Health. They are very different, these are both great institutions, but providers document differently. These different institutions have very different things that are happening there. And you can capture all that nuance by custom tuning an LLM on their specific data and have a custom model for them. And we've found that to make a massive difference in the overall effectiveness of the final solution.
Wow. You kind of talked about this a little bit, but why is mid-cycle, whether it's coding, CDI, one of that great enterprise Gen AI use cases, which we're all looking for?
Yes.
And when did you realize this was going to actually work? Because you've been doing rev cycle for long before Gen AI.
Exactly. No, so we had started the company pre-LLM, right? And that was actually, the timing actually, I would like to say it was perfect strategy. It really was not. It was a lot of luck and some good decisions, I would like to think. But But what ended up happening is we built great pre-LLM products that tackle parts of the revenue cycle that were less complex, but still important. When LLMs happened, we realized we could unlock all the parts that really required deep understanding of the medical record, and probably the part that is the most sort of woven into the medical record is the mid-cycle, CDI, coding. And if you think about it, it is the edge between the provider and the payer, right? Like that is where the healthcare encounter is coded is into a claim. It is the actual edge between the provider and the payer is the mid-cycle. So it is a very high leverage, very powerful point in the entire ecosystem, and you can now unlock that with LLMs.
Interesting. How are you seeing leading systems deploying these Gen AI powered tools at scale? And how do you ensure that the documentation or the coding doesn't go wrong? Because I think that's one of their biggest fears. What if it screws up?
Yeah, it's a great question, and we work to be very thoughtful with our customers. A good example is to look at Cleveland Clinic, right? So Cleveland Clinic is a very forward-thinking, very progressive organization, and they have been great partners to us in rolling out these types of LLM-based tools. And so they are now processing 100% of their inpatient coding and CDI through our LLMs. Now, the way we're doing it is an AI copilot, right? So we have an AI copilot that supports their internal rep staff in doing their work more effectively. So there's a human in the loop that is double checking the AI, and they work together really well, where the AI is able to read through those 50,000 words in a second, right? And then surface things to a human to make sure it's correct. And the human gets the benefit of making sure they don't miss things, because of course it's likely for them to miss things when there are 50,000 words for them to read. And so that type of model has worked quite effectively with Cleveland Clinic and our many other customers that use our products.
Yeah, that's awesome. We did a great video with the rev cycle leader at Cleveland Clinic.
That's right. Yeah.
People should go check that out on Healthcare IT Today as
Click
well.
here. No. Put a button there.
Yeah, we needed to add that extra feature. That's awesome. What are some of the outcomes, though? For whether it's Cleveland Clinic or other health systems that you're working with, what are you seeing as far as outcomes?
So our North Star is accuracy, right? Our North Star is accuracy. The point of what we're doing is making sure the documentation that is created and the claim that is created is as accurate as possible. Codes that shouldn't be there, we make sure they're not there. Codes that should be there, we make sure they are there, right? So if we do that correctly, we make sure health systems get full credit for their care they've delivered, and also the work they do gets done most efficiently. And then from a documentation perspective, remember, like the ultimate documentation that is created as part of their record lives with them for the rest of their care journey, right? So if there are gaps there, it is really critical that we capture those and we really have a complete record, because it influences all the care that they get in the future. So we've seen some remarkable improvements in accuracy of the overall record, the claim, and it's meant that these health systems get full credit for the care they deliver.
That's awesome. What do you see coming next? Like, what's next for this technology and for healthcare organizations that want to embrace it?
So the reality of the revenue cycle today, especially in these very complex areas like coding, they do not have the people they need. They literally cannot hire the people they need. This is a workforce that is aging out. People are, and there's folks are not coming in to replace folks at the appropriate speed. The amount of care being delivered is growing, and so you have this problem where if you don't do something, we will literally not have the workers to do the work. And so the approach we have taken with AI copilots helps, but what we think needs to happen and what we're working towards is being able to do parts of the work fully autonomously without needing oversight. Now, we want to be very thoughtful about how we do that and when we do that. But the things that are in production today, in practice, the way they work even today, these AI copilots, is they are actually autonomously doing the work themselves. They are fully autonomously doing the work, but the way a user interacts with them is it autonomously does the work and it suggests things to the user. And so over time, we can start seeing, hey, where are they generally correct? And you can start saying, hey, for these areas, we think we can have the AI do it. And that's going to be, we think, so impactful for revenue cycle leaders who have so much difficulty staffing these very important teams today.
Interesting. So you're basically taking the data and saying, hey, we've already coded it, and 100% of the time they always just approve it over the last 6 months. Why are we doing that? Is that kind of, why don't we just make it autonomous?
That's partly, yes. We think there will be a human AI collaboration for quite some time. But to your point, if there are areas where the AI is effective by itself, that makes sense to do.
Yeah, that's awesome. Well, Malinka, I always love learning from you and the people at Akasa, taking the latest tools to make a challenging problem easier for the healthcare organizations that are doing it, and more importantly these days, to get paid. Get
Sure.
paid for the work that they're doing. I think that's what every provider organization wants from their payers and from their rev cycle. So.
Yeah, I think everyone just wants to be treated fairly and get the fair degree of credit.
Exactly. Well, thanks so much for spending time. I know you're a busy schedule here at Vive, so appreciate you sharing your insights and perspectives. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting applications. Thanks.
Thanks so much.